Welcome to Coffee and Cases. This morning we have quite a cool presentation just around a few cases that were completed within the rocket space in the last few weeks. The focus is going to be on these two patients who, by all accounts, should definitely not have survived the condition that they were in, and yet both of them, it seems, are neurologically intact and in the process of being discharged back to normal life. The whole point around these two cases today and the conversation that hopefully we'll have is just having a look and a deeper think about futility and ROSC, what it means to keep going when sometimes the patient and the risk of futility looks like it's overwhelming. Before we jump into the cases, I just want to make sure that we're all on the same page around the fact that this is a learning environment. The idea is really to share some experiences and some thoughts. Reflections are really useful. The mics are all currently muted, but will be unmuted when it comes time for questions. But please feel free to type into the chat if you have anything in the meantime. We are about open, honest discussion, but in a kind and thoughtful way. And as far as possible, obviously, the details of this presentation are private in terms of the patient's data. So at every point, we're going to not mention patient names, details, hospitals, facilities where they were from or to, and then just make sure that we're not putting the patient at risk in any direction. We'd really love to hear your voice if you have had a really cool case or a difficult case or one that just went really well, and we'd like to share those experiences out. There is a link that you can now use to submit a case. It will appear on the Coffee and Cases register link when we're finished. And what we do need to do is just collect some data around that case to make sure that it is safe for presentation before that happens. We're going to jump straight in. I think, Brian, you wanted to present first.
Good morning, everyone. On the 1st of May, we were dispatched to a provincial hospital, which was about just under an hour's flight from our base. For a patient, it came in as a query MI. The patient was unconscious and being manually BVM'd by the staff because there was no ventilator. So the details, essentially what we got was the patient was unconscious, query MI before evacuation. So when we arrived on scene, there was no real ground support. They closed off the road in front of the hospital, but because of power lines and hazards, we had to relocate to a nearby field. There wasn't an ambulance available from the provincial side, so we had to pile all of our equipment into the back of the RV from the provincial manager, and then jumped on the back, made it to hospital. So this provincial hospital is a small district hospital. There was a one medical officer on duty. I think it was actually ComServe, if I'm not mistaken. A two-bedded casualty. Both beds were occupied. One was occupied with our patient, and the other was occupied with another P1 patient who was in the process of having an IC drain inserted. So when we arrived, essentially, we found an adult male, around 50 years old. He had a peripheral IV line up. He had been intubated orally and had a nurse who was using a BVM without a PEEP valve and just manually bagging him. He appeared in a critical condition. His clothing and the pillow and bed were saturated through, so he looked like he was in shock. You could see from the get-go that he was really not well. So we ice cold to the touch. We attached our monitors and immediately found that he was in a severe brady with no real blood pressures, saturations. Although we picked up a saturation of 97, he had no respiratory effort, and that was questionable. So we cycled the blood pressure. We got a pulse of 47. We got a blood pressure of 115/50, but then lost it. So I don't think it was an accurate blood pressure. And he was essentially peri-arrest. So he had one peripheral IV line on the left arm, and he had a peripheral line running in the right foot, which under telephonic communication had one of the one of the consultants online had given the MO in the casualty instructions of how to set up a dirty adrenaline drip and run that. So that gives you an idea of the level of competency in the casualty. So this patient had been admitted around 3:34 p.m. that afternoon with a history of collapsing, brought in by his friends, unconscious. So we arrived there just before 9 p.m. So in the interim, very little had been done for the patient. So essentially, I had a quick look. He was severely bradycardic with wide complex ventricular rhythm. So we gave a push dose pressor just to try and get some kind of a rhythm back. There was no response. Increased the adrenaline, placing pads on the patient, and he was notably cold. He was actually ice cold to the touch. Pupils were dilated, non-responsive. There was no meaningful movement. There was no movement at all. There was no respiratory effort. Occasionally he would give a gasp, but that was basically it. So recited the adrenaline. I'm just trying to remember back. So then he was essentially remained bradycardic, unresponsive to the adrenaline. We gave another push dose adrenaline. He was still unresponsive. Blood pressure, pulse came up to 44 and then dropped down to about 28 beats a minute, and then went into an idioventricular rhythm. So we decided we were going to pace him because he was unresponsive to adrenaline. So we started pacing, had a good response from the pacing. We got a good physiological capture at 100 milliamps. Blood pressure recovered, got a good pulse. So we paced him at 70 initially. Blood pressure responded 152/41. SATs came up, ETCO2 responded, came up to 30. So that was great. We got a win there. So contacted clinical, had a good discussion with clinical about this case. So initially we thought it's not a viable resus. He's basically been lying there for 5 to 6 hours with limited cardiac perfusion. So we were worried about cerebral perfusion. I say the pupils were basically fixed and dilated. So we weren't very enthusiastic about a positive outcome for this chap. But once we paced him, once we got a decent blood pressure back, that was great. We had him on demand mode, and then after pacing for about 5 minutes, his inherent rate took over, and he actually started getting a pulse. So his rate was 102, blood pressure stabilized nicely, 152/41. ETCO2 was good. His inherent rate took over, so obviously the pacer kicked out. He maintained on his inherent rate for a few minutes and then went into a VF. So identified the VF, ETCO2 dropped, so immediately shocked him, jumped on the chest, got good compressions going, went through the ACLS algorithm, cycle of CPR, checked the rhythm again. It was a shockable rhythm, so we shocked him again, back on the chest. Instead of waiting for the next pulse check, we gave an early dose of adrenaline, which worked, and we got a ROSC back. So that was fantastic. We now had a ROSC. He had a pulse of around 80. He had a relative sinus rhythm, still a bit idioventricular, but it was something. So his ETCO2 was sitting around between 30 and 40. Temperature, like I say, was still ice cold, still no respiratory effort with the occasional agonal gasp. Blood pressures, then obviously, as he got a ROSC, all the adrenaline kicked in, and his blood pressure responded very well, but he remained bradycardic essentially. And then he started, his heart rate started dropping down into the 60s, into the 50s. So again, discussed with the clinical, and we gave him a trial of atropine. So we actually gave him 3 milligrams atropine, to which he responded pretty well. Heart rate picked up nicely, over 100 again, blood pressure stabilized. ETCO picked up really, really well. We got the temperature probe on, and his temperature was 31.4. So he'd been in the casualty by the casualty door for that whole period. It was rather chilly that night, so he hadn't had any blankets on him. So we covered him. I say we didn't have any access to warm fluids. The oxygen in the hospital wasn't working, so we couldn't connect our oxygen up. So we were running in portables. We were also time critical for the patient in terms of storm weather in the area. And then we had to make a decision whether we're going to move this chap or whether we're going to leave him there. So we decided we're going to move him an hour's flight to the receiving hospital, loaded him. We started him max dose adrenaline, which he was not really responsive to. Went through the H's and T's. We couldn't rule out electrolyte imbalances because we didn't have an ABG now that did the hospital. So we essentially loaded him in the heli, put a heating pad on for active heating. In flight, we had to give him additional 0.5 and 0.5 atropine just to keep his heart rate up, which it did. GCS remained 2 plus T without. ETCO2 on handover was good, was in the 30s, 35. And we handed him over with a pulse rate of 88, blood pressure of 163, ETCO2 of 36, and we had managed to get his temperature up to 33 core temperature. And SATs were variable, 90 to 80-ish, but he was also peripherally shut down and cold. And with the high dose adrenaline, we weren't really counting on the SATs too much. Once we got him into the casualty to hand over, we got a blood gas, so his pH was 6.95, so he was severely acidotic. PCO2 was 63, potassium was 2.9, so corrected was in his boots. Of course, we could have identified that as an H&T, but we had no means on the scene, so that was corrected in casualty. Lactate on handover was 9.9 and glucose was 20.4, bicarb 13.6. So in casualty, they corrected the electrolyte imbalances. They gave him some bicarb to correct the low bicarb and correct his acidosis. He was admitted to ICU. He was also in acute renal failure. He was nursed in ICU for about 2 weeks and then stepped down to the ward. We saw him on this week, Tuesday, and had a chat to him, GCS 15. He had no neurological sequelae. He was walking, talking, 100% intact. So that kind of blew my socks off because it was completely unexpected. So really fast, succinct.
Awesome. Thanks, Brian. I think we're going to come back to some discussion points once both of the cases have been presented, but I wonder if maybe you could just share some of your reflections immediately after the case and sort of what changed now that you know what the outcome was like.
So first of all, the diagnosis. Obviously, when we arrived there, we had in our mind it was acute myocardial infarction because that's what was handed over to us. When we got there, we started checking out the patient, had a look at their 12 lead that they'd done on admission, and there was nothing that pointed to an acute STEMI or major STEMI. So it could have been an end STEMI, but that didn't really fit the picture. In terms of toxidrome, there wasn't anything that stood out. I mean, there was no cholinergic crisis. There was nothing that we could point to. So because he was unresponsive to the high dose catecholamines, we started to think maybe there's some kind of a toxidrome happening that we have to look at. And that's why the pacing and the atropine and so forth. But there was nothing definitive that we could point to say, okay, this is probably a beta blocker overdose or some kind of a organophosphate, because he didn't fit any of the pictures. Like I say, we did consider palliating the patient quite a lot. So I should have said once we first arrived, we put the ultrasound probe onto the chest, and you could see he was hypodynamic. There was really poor global contractility. There was almost no output. There was no effusion, so we ruled out a tamponade. But we really didn't think there was much hope for the patient just because of the long time prior to our arrival. We didn't know exactly what care had been given, but whatever care had been given was definitely suboptimal. So I think he was hypoxic for some stage. I also think that this prolonged hypothermia and severe hypothermia did impart some neuroprotection, and that's probably what allowed him to walk away largely unscathed. reflections, I think I definitely will think twice about terminating, especially in the hypothermic patient in this case. Yeah, you know, it's not my first rodeo, and I really didn't think there would be a good outcome. So even once we'd get him to hospital and we corrected all the H's and T's, I really didn't think that there would be a positive outcome because of the prolonged downtime, because of his prolonged hypoxia, and because of the poor perfusion. It still blows my mind that he's has no neurological sequelae.
And I think just to jump in on the hypothermia sort of picture, the idea that we had and sort of the info that we had, it seemed like the patient was warm when the event happened and then became cold sort of through the treatment process, rather than was cold, and that was the reason for his the episode that got him into trouble. So it was a weird one of like, is it a chicken or egg? Was the patient cold and then became really unstable, or were they had their event and became really unstable, and then because of the treatment process and being in a facility without a lot of resources, got cold while lying there. And because we thought he was cold because of the treatment process and not from the beginning, it felt like the outcome was going to be really bad, because it seemed like he got cold because he just lost the ability to maintain his own temperature. It was a very strange case.
Yep. And they say he was severely diaphoretic. He was soaked through. He had no blankets on him. He was sitting at the casualty entrance door. It was a cold night, so that just it was a comedy of errors from the treating hospital side that ultimately I think proved to be in his favor.
I see Sandile is asking if the facility was accredited. I think we're being a little hard on the facility just in terms of the fact that it is a very far away facility from anything that they just don't have access to a lot of the stuff. There is a lot of facilities in the country and out of the country, but a lot in our country where you've got the best meaning practitioners with very, very little equipment. And they just, I mean, if you ever think about it, the two-bedded ICU, the two-bedded resus was both full with a single practitioner and one or two nursing team members in the facility at the time. So a super small facility.
And
Um,
to the treating
sorry, go on.
doctor's credit, I mean, while we were busy with our patient, he was busy resussing that. He initially was inserting a chest drain, and then the patients arrested on him. So they were doing an active resus in the bed next to us. They didn't have a nasogastric tube. They didn't have anything larger than an 18 gauge Gelco. They just don't have the equipment or the facilities to manage these patients. And again, not for any fault of their own, it's the system that drops them in the poo.
Yeah, for sure. And I think working in limited resources makes life really difficult, especially with two really sick patients.
Morning, everyone. Thank you, sir. My issue that actually make me put up the question is actually a concern on the system itself, and not the individuals.
Okay.
It's more on the system, on our system. Our system is very bad sometimes. The public system is very bad sometimes, and it raises a lot of concerns. Because we do,
100%.
yeah, it's like no one is actually doing quality assurance, but you have quality assurance managers within each of these institutions, which now begs the question to say, what are these quality assurance managers really monitoring if you have a casualty that has one practitioner, one nurse, what is it really? So it's really concerning.
I
It's a
think when
great case.
we open up that can of worms, we're going to find lots of facilities with massive problems.
For sure.
Yeah.
Great. It's a great case. Well done, guys, for giving the patient the benefit of the doubt, which is also very important. And I think the experience that you guys have also sort of like shown and came out to say, okay, it looks non-viable. However, based on the conditions that we are faced with, we are going to give a benefit of the doubt. Otherwise, anybody else would have decided to call it, you know. So well done, guys.
Awesome. Thanks, Sandile. Let's move on to Etienne and Moses. You guys can tell us about your case, and then we have some talking points to sort of highlight some ideas.
So just brief overview. Moses will continue further. So brief overview of the case. A 69-year-old male patient, active MI, brought into a facility in Krugersdorp around about 2 o'clock in the morning. We got activated a couple of hours later on request for the patient to be flown to a facility in Klerksdorp for specialist cardiothoracic care. I think Moses, once I'll do the presentation, I think you'll fill in the rest of the gaps. Just some brief background of that patient as to what we will discuss and what happened forward.
So this was a very rapid activation because as we received the request, I was actually sitting at flight desk and Etienne was in the office next door. So we got ready very well, relatively quickly. And then, yeah, we took off and then it was a short flight to the hospital. The only info that we initially received was that it was an MI that presented in the AMs of that day. So the case request came in around 9 o'clock. The event occurred around about 2 that morning. So it had been 7 hours since the patient had been in the facility, but we didn't know what interventions had been done for him, except for the fact that he was now going to a CT surgeon for open heart surgery. While we were in flight, that's when we started getting further updates to say that he actually has a ventricular wall rupture that's also presenting with either an effusion or a tamponade, but something that required imminent decompression. So that's just the overview of the timelines. So it was last week Friday, Sonia and Kumo at the desk. We had Pierre and Denzel in the cockpit, myself and Etienne in the cabin. And the briefing for that morning was that the greater part of the day was clear to fly, except for between 8 and 9. And literally, as the weather lifted at 9 o'clock, that's when we received the case. Cool. So the referring facility was a short hop from Rand Airport to where it's situated. The initial clinical information was the MI since 2 o'clock. Patient had been to cath lab, but we didn't know whether or not they were able to lyse. And the treatment that he was currently on that we were going to carry on for the transfer was an infusion of adrenaline, Dobitrex, midazolam, and some maintenance fluids. He was also already intubated and ventilated. The receiving facility was a bit further from the referring facility, so the total flight time with the patient would have been approximately an hour or just below. And then the updates that we received literally about 5 to 10 minutes before landing was that there's a rupture of the myocardium in the anterior septal ventricle. There is a tamponade. They were busy decompressing in some form of pericardiocentesis. And I think just before landing, there was a private message that came through to me from flight desk that it looks and sounds like the patient is crashing. And the reason I'm highlighting that is because it was at a critical phase of the flight. So I actually texted that information to Etienne, despite the both of us being on the same aircraft, because if the pilots had that information while they were concentrating on the pre-landing checks, it would have then interfered with the safety of that phase of the flight.
Very much. I just want to add in there. So
Sure.
As we landed and we made our way, so obviously we landed off-site because the facility doesn't have a helipad. As we made our way through the casualty, everybody was well aware of the patient that we are coming to fetch. So one of the nursing staff in the casualty said you're going through to cardiac ICU and good luck. Good luck with the patient. They did 2 pericardiocentesis now and it's still not looking good. So immediately on that, everybody was like, okay, we're going to work here, or either it's going to go quite good or it's going to go quite bad. So if that was any preparation.
And just to throw a spanner in the works, I remember as we settled in flight, I said to you, this is an early start because I haven't had breakfast. So that was just a cue to you to look out if I'm slacking a bit because of imminent hypoglycemia. And your immediate response was you were actually pressed, your bladder is full. But nonetheless, yeah, so we became acutely aware that this is a sick patient and it's going to go one of 2 directions. We're going to be quick on the ground to try and get him across to the specialist, or we're going to have to pull all stops to make sure that he's completely stable before we attempt to move him for this long flight. Just a highlight of the sequence of events. So 10 minutes after activation, we took off. This was purely because we needed to top up fuel based on the distance and the direction of flight. We landed 24 minutes later from takeoff, and we were driven by a local ambulance to the facility. We were met at reception, as Etienne has alluded to, and I was the first one to walk into the unit because Etienne had to use the boys' room just for a brief period. And on approach to the cubicle where the patient was lying, it was not looking good. So I said, "Hi, I'm Moses. I'll just give you guys a second while we're waiting for Etienne, and then we can get a quick handover when the both of us are here." And the referring doctor looked at me in the eye and he said, "I don't think you will be moving this patient just yet." And I said, "All right, how can we assist?" And at that point, Etienne walked in and he said to me, "Is it a resusc in progress?" And as Etienne said that, they had literally just done a pulse check and confirmed that it was absent. One of the nursing sisters jumped onto the chest. There was already someone BVM ventilating or BVT ventilating the patient. And the doctor was sort of running the resusc from obviously the flow, the progression, getting pads on, getting drugs ready, and all of that. So we started making suggestions because we hadn't received the handover and we obviously didn't want to overstep the mark because the patient was still, for all intents and purposes, under their custody. So we got a metronome out. We started between the two of us. We didn't really assign a specific CPR coach, but when we identify areas of improvement, we intervened gently. And it really didn't take long before we were all in sync. And I'm talking about a space where there were 2 doctors, 3 or 4 nurses, and then the 2 of us from HEMS, plus the 2 people from the ambulance. So a situation like that can very easily get chaotic. But in that entire duration of this process, at no point did it feel cluttered, overwhelming, people talking on top of each other, disagreeing, or whatever the case might be. Communication was professional. We were all calm, speaking in soft voices, closed loop communication to a point where the people that were on the chest were able to hear the metronome. And I'm talking about a unit where it's not a private cubicle. There were other patients adjacent to this patient. I think one of them was receiving physiotherapy. So yeah, the progression of the resusc is, we thought it had just occurred, but on a little bit of investigation, they actually said to us, they've been in and out of cardiac arrest for the last 30 to 32 minutes. And I don't think during that period, Etienne will correct me, but I don't think during that period there was any shockable rhythm, but they had been giving drugs, primarily adrenaline and other sort of drugs to correct the gas. I think they did a potassium shift at some stage. And then with us, the first adrenaline went in once we were part of the team. And then with the next rhythm analysis, he was in a pulseless VTEC. They had already attached the pads and he was connected to, I'm not sure what the model is, but it's a neon code and thingy monitor. And this is sort of a blind spot from my side, not having practiced with it in a long time. The nurse that was close to me, I said to her, for the meantime, just crank it all the way up. We can figure out specific joule settings once we've gotten back onto the chest. So we pushed 270, we defibbed, we resumed CPR with the new compressor. And at that stage, we still had the same person with BVM ventilation. And bless her soul, she had good intentions, but she was hyperventilating the patient. I think she was just overwhelmed by the entirety of the case. There was a period where I did coach her in terms of the rate and just squeezing the back just enough to be able to get chest rise. It's obviously difficult during chest compressions, but I would hope that someone who's done BLS is following what I'm trying to say in terms of how we're coaching her. And then, yeah, the next rhythm analysis, pulse was still absent. There was a rhythm change. It was a VFib. We kept it at 270 with defibbed. We resumed changing compressors. There was a period where also myself and Etienne alternated with chest compressions in between clinical consultation. And then 15 minutes since we walked into the unit, there was a change in ETCO2. There was a change in rhythm. We palpated carotid pulses. They were absent. We palpated femoral pulses. The right-hand side was impalpable because they had earlier attempted to cannulate a CVP and it was unsuccessful. So there were dressings in that region that made it difficult, if not impossible, to palpate pulses. I was closer to the left-hand side of the femoral. I could feel a femoral pulse. So we acknowledge that we may have had ROSC, but to confirm it, and you'll see there's a short video clip later on, we did a quick ultrasound just to see if there's contractility or not, which there was. On acknowledgement of the ROSC in between, and this was neither a consensus or a point of contention, but we were driving the conversation towards the discussion around end of life and considering termination purely because of his age, his history, his presenting symptoms. We know he had an MI, we know he had a ruptured ventricle. We know that as and when we were doing chest compressions, he kept on bleeding into that pericardial space. I think in between the compressions, the doctor did take the liberty to decompress once or twice, and I think he aspirated about 20 mils of blood at a time. So clinically, it was not looking good, the prognosis of the patient. But I think when we connected our end tidal, because during the BLS research component, there was no sort of feedback. The numbers we were getting on the screen were the reason we decided to just give it a shot and go full ASLS. And then post acknowledging ROSC, the presenting rhythm was a wide complex VTEC, which was pulsatile because 2 or 3 people confirmed that they could feel a femoral pulse, and we could identify it with the ultrasound as well, which we calibrated at 50 joules, and it resolved into some form of sinus rhythm that, yeah, I'd need years and years and years of study and wisdom to be able to diagnose it. And I'm glad the audio didn't come through because there was a very brief, like 10, 15-second discussion where someone was seeing a VFib on the screen, but majority of the team realized that because we are able to identify contractility on the ultrasound, it's probably not a VFib. A VFib would not be pulsatile or contracting. And then, yeah, it was one of those instances where, because we were not anticipating ROSC not to sound ugly, but because of the initial sort of clinical picture that we had, we were a little bit knocked out of our socks, to borrow Brian's sort of words in his expression of his experience. And then we had to take a deep breath and start afresh because we now had a new patient. So I gently moved towards the head to take over the BVM ventilation just to relieve the person that was there. I think at that point, Etienne was either on the phone with Janine or the receiving doctor or Mel Park, which will give us the details, or the family, because he basically had to coordinate a lot of communication in between this process, which felt like it took forever, but it was in a space of 15 minutes. So we did a 12 lead, and that's the overview of what we saw. We were not particularly surprised. We did a follow-up, yes. And yeah, he was in a sort of mixed acid-base disorder, but it was mostly severe respiratory acidosis that we could identify. And then we took the liberty to now get a full set of vitals, and they are as they appear on screen. So one of the initial infusions that he was on was a midazolam, which after this we decided to stop it because obviously we could not palpate a blood pressure. I think for the first 10 to 15 minutes, up to a point where we gave a push dose pressor, and then we had our first palpable blood pressure with a relatively decent map, but we maintained all the other infusions. And I think at this stage, we had come to a consensus that we're going to attempt to move this patient. I don't know if you'd like to carry on from here, Etienne.
So just to go around the clinical discussions and also around the discussions with the family. One of the most difficult things is on the initial handover, when we walked in, the family was there, and it's basically the 2 sons and then the wife. So the one son was, you could see, visibly distressed, and he, in the words to describe it, and I still remember it, was, "Please help my father." So there wasn't really as much communication from that side, which is also to be understandable if they're busy working and there's a lot of stuff to fix and that's going on. So I did take 2 minutes just to speak to the family to say, listen, I cannot promise anything, but I will keep you guys updated. Also, during the resuscitation efforts, whilst coordinating between clinical, communicating between possibly moving this patient for ECMO, possibly continuing to move the patient to the other facility, which we ended up moving to, coordinating all of those to discuss all the possibilities that was going on. So I kept the family up to date, and I said to him while the resus was ongoing, just when I stepped up briefly, I said to him, listen, this is what's going on. Effectively, he is dead. We are trying everything in our power to try and reverse everything that we can, and just gave a brief explanation as to what actually happened, because all they know and what they knew from the hospital side is that he was having a heart attack and things is not looking good. So I just took the liberty to take a quick minute and a half to just explain it further to them. So Based off of that, as Moses took over the ventilation, I quickly set up the ventilator once we established that there is ROSC and it is a sustainable rhythm. Because one of the things we actually did, and it can be a discussion point, is we said, but now that we've got ROSC, is this ROSC in the sense that we've got a sustainable pulse and it's going to sustain with itself without giving push dose of adrenaline? And that push dose, although we gave it a 10 mark push dose, referring to a full 1 milligram of adrenaline to sustain the heartbeat, or without withholding it for a couple of cycles to see if he maintains it himself, of which the patient did in that case. So you can see our ventilation settings. It was a brief ventilation. Obviously, we have a normal PEEP of 5 to 10, which we set. Still adjusted for some PEEP, just made it a little bit lower just to try and maintain hemodynamics as best as possible. Normal other ventilation parameters, trying to maintain a tidal volume of 6 mils per kilogram. At this stage, from the initial stuff that we had was a midazolam infusion, which was discontinued from our side. We only maintained the adrenaline, the Dobytrex, and the phenol. And then they discussed gelaffusion as well to do some volume replacement, because that was one of the discussions that me, Moses, and the treating doctor also had with the help of another doctor to say, but although we might need to replace some volume because we know what is going on. In that point in time, with the clinical consultation, the receiving cardiothoracic surgeon that side asked me a question, and he said to me, Etienne, be honest, are you comfortable to move this patient? And are you happy? Because it was a 15-minute flight time to estimate to the receiving. So long and short, my answer said to him, well, doc, if I don't try and move this patient, he's not going to get to the specialist care that he needs. That was obviously in conversation, waiting to see if we might change receiving facility to possibly move for ECMO, of which there was also some challenges from the referring side to say, but he's got aortic stenosis, the ECMO might be difficult to cannulate, but in which the conversation was happened, and they said they're actually happy to attempt, although with whatever comorbidities there is and possible complications to cannulate for ECMO. There was a bit of a delay in getting back, just in that point in which we said we're not going to delay it further. We will move to the first accepting facility, of which the cardiothoracic surgeon also said to us, listen, he will meet us on the field and do a pericardial drain if it needs to be that side. So in terms of the patient prep and packaging, so airway was well secured, 7.5 millimeter ETT. We checked the cuff pressure was okay, 23 centimeters at the teeth. No spontaneous breathing efforts from the patient post-ROSC, also entirely ventilator and BVM dependent. Circulation, obviously severe cardiogenically shocked, entirely dependent on life support medications, as discussed earlier. So he had multiple inotropic supports via central venous catheter in the left femoral, because at this stage, the doctor said that he's going to change and he's going to attempt to gain CVP access in the left femoral region. Environmental ambient temperature cool mid-morning. The ICU also wasn't the hottest, although we were hot with everything that was going on, to put that mildly. And then, so yeah, basically once we connected fully onto our monitor, that is one of the views. So temperature 34.1 into the left axilla. He was cool to touch. So we kept that temperature and we covered him with a blanket and we packaged him inside a vacuum mattress as well, just to try and maintain that heat as best as possible.
So if you can jump in, Etienne, if you look at the timestamp on the top left corner of the screen, it was 11:18, and that's the time that we were actually starting up at the referring facility. So to give you context, we got to the patient side at 5 to 10, and an hour and almost 30 minutes later, we were starting up to then move him. So obviously the stabilization post-ROSC took a bit of time, because we all needed to be sure and to be comfortable that stable is not the right word, but let's attempt to move him. And we're going to escalate to the discussion that Etienne and I, we had, that what happens if it does deteriorate in flight.
Thanks for that, Moses. Just to add, you can see the CO2 there was sitting 42. So he was hovering between 38 and 40. And one of our biggest decision makers to continue the resuscitation is when we walked in, our very first vital sign effectively that we put on and connected was our CO2, just to see, because if the CO2 was sitting at a 10 or an 8, that would have stimulated the discussion even further and possibly pushed us towards the decision of terminating the resus. But at that point in time with the CPR, the CO2 was sitting actually at 28. So we decided that's definitely a CO2 that we can continue to work with, and there might be some viability. So here's just some images. It's shared with the family's consent and also from the cardiothoracic surgeon. So basically, when we arrived to the facility, went straight to theatre. So you can see there's an anterior wall rupture and a posterior wall rupture, which led to the cardiac tamponade. Patient was in theatre, if I can remember correct, for about 4.5 hours, and from a direct translation towards the feedback of us to say it was hairy, to say the least, but he pulled through. So in flight, effectively, we continued the phenol, we continued the Dobytrex, and we continued the adrenaline. So adrenaline was running at 0.8 mics per kilo per minute, which is, of course, exceptionally high, but that was needed to maintain his perfusion. The Dobytrex was at 15 mics per kilo per minute, and then the phenol at 0.5 mics per kilo per minute. Just in terms of our standards of care, one of the biggest changes we made just after loading is to see the volume, because we usually in our standards of care within the rocket space, it's 3 milligrams in 50 mils for the adrenaline. The rate was exceptionally high, and then we might have to top up. And obviously with the patient being so inotropic dependent, any delay within the inotropic support might cause a further deterioration. So we elected to change over, of which I put 5 milligrams in 20 mils and just calibrated via special functions. And that bought us an hour and a half, which will be sufficient for us, first of all, to land at the receiving facility, but also then to make it safely to theatre where they had everything prepped. Moses, I don't know if there's anything else you want to add.
I don't know if Sonia and Kumo are online, and I don't know if Janine is online, because both their context is just as imperative as what we've given you from a clinical aspect. And the reason I'm saying this is because we were constantly back and forth with them on the line. If my hands were tied, Etienne was on the phone with them and vice versa. But we had the specialist and another doctor waiting for us at the field when we landed, that if the patient required emergent intervention there and then to buy him time just to get to the hospital, they were prepared to do that. And we even went as far as preparing our ultrasound for them to be able to use it if they needed it. However, when they walked into the ambulance, the first question they asked me, were there any significant changes in flight? And I said to them, he is very sick, as you are aware, but in flight, there were no variations that we could say were outside of what we started with when we packaged him and moved him. And they said, based on that feedback, we're happy to just load him and move him straight to theatre, and then we can intervene in a much more safe and controlled space. And then we started getting updates from Janine. Basically, we've been getting them from the day of the incident, which was last week, Friday, up until I think Monday afternoon. So if she is online, I would like to invite her to please provide us with those updates that she got from the treating specialist.
Thank you for activating my mic. I think this is an absolutely phenomenal case all round, and a good learning one. I don't think the outcome would be anything like this if the receiving specialist was not so phenomenal. He was just as invested and just as prepared to give everything a try. So the latest update, obviously, theatre, he had about an 85% mortality rate of dying on the table, which he did not. He has still managed in ICU thereafter, and the latest update is that he is being extubated. He is able to respond, follow commands. He is neurologically intact. He is pretty much off of all inotropes and vasopressor support, and it's just hanging in there on his own.
Madness. Thanks, Janine. Thanks, Moses. Thanks, Ed. I wanted to maybe start out by opening up to any questions from the bigger group. I see, Shona, you put your hand up and then took it down again.
Now, good morning, everybody from Saudi Arabia. Thanks very much for presenting these two cases. A couple of things I just wanted to ask. The rupture of the ventricle.
What we were updated from by the specialist was that the symptoms of the MI and the actual MI itself had been from 8 p.m. the night before. So I think that might have, led to progressive wall weakening, and obviously with the abnormal cardiac motion and things like that, it just might have hit a soft spot. So I'm not sure if that was the reason he was going to ask why there was a ventricle rupture or tears, but it was likely that it was quite a prolonged MI, not as sudden as was possibly initially thought, and that led to wall weakening and the picture, but we'll see if it does have anything further.
Thanks, Janine. I see Tom's back.
Hello,
Tom?
Can you hear me?
Yes, you're back.
Sorry, I don't know what happened there. Thanks. Yeah, my question was about the rupture of the ventricle. Do you think that could be associated with the aortic stenosis as well with regards to back pressure? Just a thought. And then also, this reminds me of, first of all, this case, phenomenal, guys. What a fantastic job. I mean, I think the cardiac gods were out to get you on this day. But to pull this guy through is nothing short of a miracle. So congratulations all round. The pericardiocentesis, I had a case many, many years ago where we had a similar case, a cardiac tamponade, where we were doing a pericardiocentesis, and during the flight, we were actually withdrawing the blood and auto-transfusing back into the IV. What were you guys thinking should you have to have carried on with that pericardiocentesis in flight, if any?
Etienne, your hand is up to answer, I think.
Thanks, Tom, for that. So basically, our decision making to the point effectively came in. So we involved the cardiothoracic surgeon, and he said if we are going to have to MacGyver by even putting any sort of form of temporary pericardial drain in, he'll be happy for us to do that, of which the referring cardiology team and also the doctor that side weren't pretty comfortable to do. So in our point, we said obviously we are, first of all, not, although we have ultrasound, I'm not that confident in my ultrasound skills. It's also not within my scope of practice that I will be comfortable to do that. So effectively our point in care, and I think this is what even Moses wanted to allude to say, should something else go wrong in flight, what do we do? And our decision was to say, depending on the duration, is to first of all just continue CPR because we know the reversible cause. And I think that's also where the communication came in, to say, let the receiving cardiothoracic surgeon meet us on the field that should you need to do a pericardial drain right there and then, that it will continue to be done there.
And sorry, were they prepared? And it's a big ask, but if you were coming in hot and this guy had arrested again, etc., apart from doing a drain, were they prepared to do a thoracotomy at site before getting into the hospital?
Yes, so that cardiothoracic surgeon literally had everything prepared. And that, once again, kudos to them and kudos to communication from the rest of the team to have everything prepared. Because effectively, when we landed, I said to Moses, I'll jump out. I'm just going to give him a quick handover. And he said, well, it seems like he has, as much as he's unstable, he's stabilized, that he's happy to move from here to theater instead of doing anything on the road. But he had literally everything prepared with him.
Yeah, once again, guys, what a fantastic job. And it certainly speaks to communication. It speaks to the chain of survival, and it speaks to everybody doing their part, and especially on the receiving side. Kudos to everybody. Thank you.
Very cool, two cases. I wanted to maybe just ask both of the teams some questions along the way and sort of try and get into your mindset as you were with the patient. I think Moses already alluded to a few of the things that helped make a decision. But I think maybe the first question we want to ask is, how do we decide if a patient is presenting with a futile situation or if we are dealing with a temporary catastrophic physiology? And how did you apply the concepts that you did, and what did you apply to try and make those decisions for both of your patients? So maybe I think with Moses and Etienne's first in mind, let's start with you guys and then move back to Brian for the other case.
So because it was a relatively acute event, I mean, our initial clinical info before Janine gave us the much more broader sort of insight into the onset of symptoms being 8 p.m. the previous night, we thought to ourselves, we can't just walk into a space where this patient has been with this team for however many hours and not give it a try. And what also sort of very quickly became apparent was that the team that was looking after him is a team that is sorry, I'm getting distracted by messages on my phone. I do apologize. It's a team that was invested in him, because as soon as we started, and I'm going to use the term driving loosely, but we started driving the resource, because there was a point where I volunteered and I said, not to be cocky, but I am an ACLS instructor and I'm comfortable leading the resource if you guys are happy, and everyone was in consensus. Then we started gelling, and that didn't even take a minute. However, because again, we were all aware of how acutely ill he was, when the conversation towards end of life was also making its way in between getting the pulse back and then losing it, or having a shockable rhythm and then back to an unshockable rhythm. If it had gotten to that point, I don't think it would have been a decision that would have been met with contention. Anything we could have done differently? I can't think of anything at this point, unless Etienne has got something to add from his perspective.
I personally, if I were to do this case again, I probably don't think anything would change in that space. I know that the communication, first of all, between us, because the conversation went on to say, is this a torsades? Is this something else? And it was literally a 2-second discussion between everyone to say, should we give magnesium? Should we give calcium? And everybody was on the same page to say, we won't know unless we try. And therefore, it was the moment it was ordered to say the doctor go ahead, the nurse was like, yes, 1 gram of magnesium sulfate, doc. So everybody had that thought process of thinking ahead, thinking of any reversible cause. And when they thought of something, it was immediately brought up to say, but have we considered this and have we done that? So that was a compliment to all. Just something that I wanted to add, and I think we do end up not taking too much cognizance with this, with our high cognitive load within situations, especially situations like that, is making the family aware. And I remember I was actually on the chest doing compressions when I saw the son standing by the door looking at what we're doing. And as the switch happened, I said to Moses, I'm stepping out, first of all, to check on the clinical progress as to where we're moving to and if we're going to move. But I'm also just going to point out and active feedback to the family. So I think as a holistic, one thing that we can do is to, if we've got the capability and the availability of personnel, especially within a unit specifically, and even on the road, and I know it's difficult, but to almost form whoever's running the CPR, or to use the CPR coach, whatever, if you want to go into the ACLS side of things, to sort of form a liaison officer to just either discuss with if does the family want to be present, or at least intermittently just give them updates as to what's going on. So if there's anything that I would have changed, is to possibly factor that in as well.
Thanks for those answers, Brian. Any thoughts from your side? What are some of the things that are kind of keeping you in the idea of, is it futile, is it not?
So I'd like to bring Chris in as well. He's woken up, so he had a really late case this morning.
Welcome, Chris.
So for this patient, because he didn't present with any normal presentation, so we didn't know, did he have an MI? Was he a tox? Did he have a massive intracerebral bleed? There was no definitive to guide us. And because he wasn't responding to really high dose, I mean, we'd maxed him out on 3 micrograms per kilogram per minute of adrenaline with no response. It was really down to, let's try the pacing and see if it works, because we have no other options here. Again, so I mean, Chris and I discussed how viable is this case, because he'd been there for such a long time. He was cold, he was unresponsive, pupils were fixed undilated, predicted clinical course wasn't good for this chap. So we really did think it was futile, but yeah, we were there, so we might as well give it our all.
Okay, good morning, everybody. Yeah, sorry, I'm a bit late to the party this morning. I agree with Brian, and I think it's one of those cases where, having seen many cases over the years with similar presentations and similar progression, we just didn't think that there was a viable outcome for this patient. Nothing was working, the adrenaline wasn't working, and the idioventricular rhythm didn't really look compatible with life. So we had a discussion among ourselves of how far should we actually push it. And the hospital staff were kind of, I won't say taken aback, but they were like, but aren't you going to do more? You've come all the way. And we said, okay, let's get the basic. Well, we had the pads on because we were thinking he was going to go into arrest earlier. And yeah, then we decided to pace, and that worked. Added the atropine into the game, and things just changed. And we sat back later and thought, wow, if we'd gone the palliative route earlier, the way we thought would have been the kind thing for the person, because there's no family, no next of kin, nothing to get some background, and his colleagues dropped him off and left. We yeah, if we'd gone that route, we wouldn't have had the outcome that we had when we went to see him in the hospital 2 days ago. Yeah, that's one of those things when you reflect on it later, you think, okay, don't be jaded by everything you've seen over the years, and go in with a fresh approach every time you see a patient like this.
I really like that. I wanted to also highlight just the idea, and I think it's not something that we are particularly good at. We know that when we get into a resus, that we often don't come out of a resus. Do you think that you guys on both sides were adequately prepared for the ROSC? And what could you have done to sort of make that first 10 minutes post-ROSC better if you had been expecting the ROSC? And I ask that because I know that I'm always absolutely astounded when we get a return of circulation, and that's usually where things go really badly. Our resuses are super structured, and then we kind of look at each other and high five, but don't know what to do next.
So again, this was a blind spot from my side, and by the time we identified it, it wasn't too late, and we were able to rectify it. But we had that prolonged period where there was a degree of hyperventilation, and this is not to bash anyone's practice, but obviously it does happen from time to time. By the time I stepped into that role, I think for a good 5, maybe even more minutes, I literally did that and nothing with intermittent pulse checks in between while the other stuff was happening, the CVC cannulation, the blood, Etienne being on the phone. It probably would have been best practice to bring the ventilator in earlier. If we could have squeezed it into the resus, great. But if we had anticipated, which we should have, and we probably were not, anticipated ROSC, we should have brought it in earlier, because when Etienne was down on the phone, I think I had lost visual of the monitor. We picked up a very short period of hypercapnia, which was obviously not ideal, but at least we knew that he is perfusing whatever volume he's got left. So that's probably one thing. We discussed it very briefly, Etienne and I, after the case, that other things that we could have considered, granted, we were pressed for time because we needed to get him to the receiving as in yesterday, but an NGT and maybe a urinary catheter, because they form part of that entire sort of management of the post-ROSC syndrome.
Thanks for that, Moses. Yeah, that's definitely something we did discuss. I think the other side of things, and as Caleb also said, with the moment you get post-ROSC, it's almost like you stand and you look at a monitor. And at that stage, I remember the doctor specifically. So our monitor routinely sets at an interval of 5 minutes. You can set that smaller, in which the doctor said, no, we need to change the cycle to every minute, which in that stage, there was a quick discussion around. I said, doctor, with all the respect, we are going to see terrible over terrible, and it's not going to change. So instead of us fixating on the monitor, let's just keep the monitor to let that do what that can do, and then we need to start preparing and packaging for this patient, in which she agreed, and she actually took the liberty of, although we have the adrenaline prepared, she actually pushed those presses for us pre-prepared, of which she drew up 100 marks to effectively make it 100 marks per mil, of which we just discussed to say, but that's out of the push those presser range. So let's titrate that down further. So we effectively had 2 presses ready to go in case we did run out, and in case we also didn't bolus from the monitor. At that point, the doctor then formally secured and made sure that the left femoral CVP is maintained, and then we prepared for the packaging. So in that sense, everything went well. So relating back to what Caleb said, is the moment you get ROSC, I think everyone is so fixated on, let's look at the monitor and let's actually look at what the values it's giving. Because I think probably one of the worst things that can happen is saying you've got ROSC and then doing all the effort and not someone looking at a monitor by the time you've done everything that you hoped you would have done to start moving the patient. We are back either into an asystole or a VF that we missed and stuff.
Thanks, Etienne. Just to add on that, summing up to give Brian a chance, something that I've been using in a lot of training in ACLS, which I brought into life, which I think it also aided in sort of driving that process of managing him as a post-ROSC patient, is to literally verbalize that this is a new patient. So immediately everyone sort of switches from that cardiac arrest mindset to the mindset that this is a patient, now we need to start over again, A, B, C, and then work from there. So I think that also aided in the sense of expediting the transition from a cardiac arrest patient to a post-ROSC patient and preparation for packaging and for flight.
Thanks, Moses. So just to add to what's been said, so because we're in such a resource low setting, we put the vent on relatively early, so that freed up one of our sets of hands. And like I said, while we were busy with our patient, there was a resus next to us, so that consumed all the available manpower. Once the patient arrested and we jumped on the chest, we also got the metronome going. We put the vent into CPR mode, so that optimized that. So without proper effective basic life support, I don't think we would have got a ROSC back. So I think that's also key, is if we're not doing effective CPR, we're not going to get a ROSC. So it doesn't matter what ACLS procedures we do. Once we did get a ROSC, we obviously regrouped. We followed our standard of care. We popped in a nasogastric tube just to decompress the stomach. The patient already had a urinary catheter, which was great. We started actively warming with the heating pad as soon as we got into the heli. Optimize our ETCO2 as best possible. The problem was that we couldn't rely on a lot of the parameters from the monitor because he was so unstable. So SpO2, even the NIBP was taken in conjunction with the whole picture as opposed to just looking at those values. But yeah, it's I think in this case it was a lot of luck, and if we hadn't done effective BLS CPR, he definitely wouldn't have come back.
Oh, you've made such awesome points. And I think this is probably where we need to be focusing all of our attention. And then the 5% of attention that we focus on the ALS stuff is really nice on top, but it's the basic stuff that we need to just get right. And as evidenced here, it is the basics. Obviously, in the second case, there was some advanced stuff that needed to happen to reverse a reversible cause. But without the basics, you wouldn't have been able to do those reversible causes anyway. I wanted to also just maybe ask a few questions around, sometimes we make a decision for a patient before we have all of the data. And so I think if I can maybe just push those of you who are running systems or thinking about systems to create some kind of safety checklist for situations that happen quite frequently, so that in the heat of the moment and in the sort of mist of war, or the fog of war, you don't end up making bad decisions simply because you can't think of something else. In those super high acuity environments, it's very difficult to think about the potential reason for the arrest and to kind of add another layer to your care. So figuring that out is quite important. Moses, your hand is back up.
Yes, sorry, this is the last time I'm commenting on this case. While you've mentioned that those systems in place to try and mitigate a potential error, without throwing Janine under the bus, and I'm pretty sure she won't have a problem with me sharing this because it was an area of learning for both of us. So the initial clinical info that she was working on when I asked for a clinical consult the first time was an AMI case that needed to be moved for urgent surgery. So the trajectory of her clinical advice was sort of along that line. And because in between that, there was CPR coaching and this and this and that and happening, I did receive that information and I parked it up to a point where it would have become necessary. But I think we either lost connection or there was another call, something happened, and then I had to cut the call and get back into the team. When Etienne and I had a chance to regroup, because we do this quite routinely, one will do something else and the other will do something else, and then we'll reconnect and see if we're still on the same page. I said to him, I don't think Janine is aware of where we are right now. And I also couldn't bring it across quite effectively via the call that we are currently researching. But I think she went back and followed the case either via flight desk or the communication channels. She immediately texted me and she said, hold off on that discussion that you and I had. I'm going to regroup and call you back, which she did. And she did spectacularly well. But she carried on the conversation with Etienne going forward because I had my hands tied when she called back.
Awesome. Really just the last thing I think that I want to ask you guys is how, going forward, how do we decide when a patient is stable or unstable enough to either put them on an aircraft or into an ambulance or leave them behind? And how do we make that decision? What was kind of guiding your thought processes? I know we alluded to a few of them. I do see Etienne, your hand is up again.
Yeah, thanks. I'll leave that question for someone else in the chat to see how they would approach that. I think from my side, I'll add, and just this is my view, to say the moment you're in a critical care environment, it's kind of you have to make peace with the fact that you are there, and if you're not moving the patient for the specialist, or at least giving it an attempt, it's difficult. I'm not going to say you're failing the patient, you're not giving the patient the best chance, and it's even alluding to say, but it's so difficult on when to palliate and to say, well, let's try and attempt to move this patient. But just a previous note I just wanted to make, and it's alluding to Janine and to Moses and to our case specifically. It's so easy to get task fixated at the moment you see your phone ring or be like, listen, someone else wants to chat to you or stuff to say, but I'm busy now, just leave me alone. It's, in the end of the day, what we need to remember, it's someone else that's trying to help you. It's someone else that's not caught up within all the stresses that you have going on. That even putting that phone onto loudspeaker, but having a 10 seconds of active listening can make a big difference on that patient, because you're not just answering the phone to say, let me just hear what this person's saying. Is they might actually come with, first of all, invaluable advice, or maybe some additions to say, listen, I've chatted to this person, we can do this, or listen, receiving has changed, instead of only finding this out afterwards. That's now adding more physiological stress onto you because you were prepared to go to that facility that you might know is not always suboptimal, and you're going to end up fighting there. So as difficult as it is, even that 10 seconds or 2 minutes, whatever, that you take a step back from that patient and that situation might be invaluable in the end for the patient.
That's really thoughtful feedback, and it's something that I think all of us struggle with. When you're under load and someone's trying to phone you, but they might have info that might inform your next step, it's really important to get it done right. Really nice feedback. Are there any questions or thoughts from the chat? Anything on the how do we decide if the patient is too unstable or stable enough to move? Stan.
Hi, thank you, Caleb. Thank you, guys. It was an awesome presentation in both cases. My question is what did you guys think the impact of the hypothermia for both patients may have affected the outcomes of the resus?
Very nice question. I think probably the most hypothermic case was Brian and Chris's, so I think let's defer to them.
Thanks, Dan. So I definitely think it was neuroprotective in this case. I think it was, so he was in severe hypothermia. So that boded him well. Yeah, so if he was normothermic, I don't think the outcome would have been as positive, and certainly not without any neurological sequelae.
Yeah, without a doubt, I think in that case, the hypothermia is kind of what saved him. That does not translate to let's make all of our patients hypothermic, though. Just so that we're on the same page.
I just find it interesting that, you know, it's South African winter is notoriously cold, and a lot of our patients end up below temperature. And I just noticed that in both of these cases, there's a hypothermic aspect, which is always, you try and chase it up with warm, or do you leave it as it is, which is also in itself a clinical decision. But yeah, no, wonderful resources and wonderful case. So good outcomes all around. That's always a good thing.
I think what's also quite important is that both of these patients were medical patients with no evidence of sort of a massive or major bleed. Obviously, the patient bleeding into his pericardial sac is a problem, but you're not going to die from hypovolemia in that situation. So if you have the medical patient, the hypothermia may be less dangerous than if we're dealing with that bleeding trauma patient. So these blanket answers don't always work, but I think knowing the temperature is the starting point for the decision. Guesstimating the temperature becomes part of the big problem.
Yeah, just, it's interesting as we discuss, things come to mind. So with the cases being hypothermic, my question to both the teams, in the prolonged resuscitation, especially in the hypothermic patient, yeah, we're very resource limited back home. I understand that. But if you don't have enough people, would it have made your life easier having an external cardiac compression device, be it core pulse, auto pulse, or whatever, especially in the hypothermic patient where we know there's prolonged resuscitation efforts with good outcomes generally?
Oh, really cool question. Etienne, Brian, Mose, Chris, any comments?
So I think, yes, it's definitely would have been first choice because we resource limited. It could have continued compressions effectively. It would have freed up hands, but cost benefit for the number of patients who we would use it versus the cost. Surely we can use the costs more wisely, or the resources more wisely. But yes, I think it would have benefit. Short-term answer, yes, it definitely would have been a benefit.
Thanks, Brian. Yeah, the reason why I bring it up, this site here, the company I'm flying with have just invested on the core pulse, and we've got them on every rotor wing as well as fixed wing. So, here resources are much more readily available, understandably, but it was just in the hypothermic case more so. I think it definitely has place for the prolonged resuscitation, but I understand 100%.
Dave, I see your hand is up.
Good morning. Thanks so much, Caleb. Yeah, just once again, phenomenal cases to these teams, and really, really have enjoyed this interaction. And I just wanted to, and Caleb, you can tell me whether it's not appropriate or not, but just to get into a little bit of clinical, I thought the opportunity would be quite amazing on the cardiac tamponade case with aortic stenosis. Now, obviously, that's not one you see every day, but just comments on the vasoactive or the inotropic and vasopressor support choices on an aortic stenosis patient. Was there discussion around that, or perhaps just some comments on there? I'd be interested to know what the crews felt about, because you guys have spoken a lot about ROSC, and in a fixed outlet obstruction on the LV outflow tract, that can make things rather challenging sometimes. And I just was wondering, maybe the points can be made for those that aren't aware of those challenges, having brought up this case.
Well, awesome question. Maybe if we can just get the crews to give us their thoughts, and if it was considered, what was considered, but also what is available, and then we'll come to Jean.
So our broad discussion, I remember on the way to the flight, I spoke to Moses and I said to him, with all the respect, it's probably although we know that there's a tamponade forming, the patient needs the contractility to work against that. So the dobutamine is, in this case, probably more important than the adrenaline. And when we arrived there, effectively, we took over in the sense of what they had already running. I know Moses obviously just went to special functions to see where within the ranges we are finding ourselves and where we can go up and down. So that was basically our broad discussion to say we know that the dobutamine is important. We understand why the adrenaline is there. And the phenol, we basically just kept it going because with no clear reasoning, if I can think back as to why we continued going, purely based on that's what they had running as well.
Thank you. So from my side, it was also a very good learning point for this specific case. Because the whole ECMO discussion came about, and what are we going to do with aortic stenosis, and can they do ECMO? And that's way above my pay grade and my speciality. When we did follow up with the cardiothoracic surgeon, he said that the patient had no aortic stenosis. I mean, when they put the balloon pump in for theatre and things, it went smoothly. Obviously, just in case anyone else wondered, aortic stenosis is not a contraindication and a reason that ECMO should not be considered. They do have ways to work around it. Again, it's not in my field of speciality. You need evidence and testing and CT angiograms for those that formal diagnosis to be made. So from our side, the specialist that's looking after the patient had said that he's not sure where he got that idea of aortic stenosis. Again, it doesn't change the discussions in the court process that Ed and most have given. But something just to keep in mind as well, which was learning for us, is just because someone said something doesn't necessarily guarantee it's true, and you shouldn't limit your treatment options or thoughts just for that.
Basically, the first comment that was made there, so let's assume there is an aortic stenosis. And so remember that is an outlet obstruction. So your ventricle has to compress against that obstruction regardless of any other factors. So your ventricle muscle is under work. So if we take the tamponade and just think about the physiology with regards to the tamponade is obviously putting pressure on the outside of the ventricle, probably more on the right than it is on the left, but certainly tamponading on both sides. And so there, it's not a pressure effect, or in terms of contractility, it's not a contractility problem that the tamponade is causing. In other words, the comment of dobutamine, where's the place for dobutamine? So if you've got a contractility problem, absolutely dobutamine is what you're looking for. But from a tamponade perspective, it's not getting the blood out, it's getting the blood to refill, which is why the volume or the preload of the ventricle is then critical in terms of the tamponade effect. With regards to an aortic stenosis, and I think this was a good point that you raised the dobutamine. If you crank up dobutamine on a fixed, and this is the point I'm making, it's a fixed outlet obstruction. You've got a constriction over your hose pipe. You can then make the heart pump as hard as it possibly can. It can't get the blood out any faster or any harder or any better because it's a fixed outlet. So you got to then be a bit careful with that contractility. Now, you've had a myocardial infarct, you've had cardiac muscle damage that may not be contracting as well. So I'm not saying dobutamine is not indicated. It absolutely may be. But you've got to be very careful about cranking up the dose of dobutamine or using it as a contractility agent to improve, because you can't improve on a fixed outlet obstruction. That's the first point. The second point is the gradient across that valve or whatever that outlet obstruction is, be it a HOCM or a valve or a supravalve narrowing, whatever it is. The more you make the gradient, the worse, the harder the heart has to work to get the blood out. And remember that your coronary perfusion is dependent on the other side of the valve. So I really enjoy the phenylephrine conversation, or the fact that you left the phenyl there, because that was, I'm hoping the reasoning behind it was to maintain the diastolic blood pressure, to decrease the gradient from the left ventricle across the aortic valve into the ascending aorta. So in other words, make the heart work less hard and maintain coronary perfusion pressure, which is obviously what your goal is post ROSC. So and that's perhaps where I was going to go, okay, is saying in this case, was noradrenaline a consideration at any point? Because perhaps that titration, and obviously this is easy in hindsight, but a dobutamine noradrenaline titration may actually work very, very well in this post-ROSC patient. as opposed to perhaps the phenylephrine adrenaline, where high dose adrenaline, which is what you required, and again, I'm not going to debate that at all. You guys did phenomenally here, but as you say, from an academic tweaking perspective, could something that's less agitated on myocardial oxygen demand, coronary demand, like adrenaline is, perhaps then the noradrenaline dobutamine combination may have got us, or you were out of trouble, but may have also been another option, in other words, for the reasons, the physiological reasons I've just explained. I hope that that's come through fairly clearly. Does that make sense? Okay.
Oh, that's really awesome. Thanks, Dave. I was actually going to ask, do you think that maybe the high dobutamine doses could have played a role in the rupture of the myocardium if it was trying to beat against this fixed outflow obstruction?
Yeah, I think you're quite right. That's, well, I don't know if we've heard now that there wasn't an aortic stenosis, but certainly if there was an aortic, as you say, a fixed outlet obstruction on a myocardium that's now weak, that's because we know that aneurysm formation can happen within the muscle wall. And I think we were alerted to the fact that this has now been a prolonged myocardial infarct, which means that you have got muscle atrophy. So certainly by making the heart pump much harder against an obstruction, that could definitely be a plausible pathogenesis. Yeah.
Sure. And I don't think it's something that we initially considered in sort of the mess that it was, but definitely cool to think about now. Thank you so much for adding that in, Dave. Awesome. Thank you guys so much. Are there any other questions, comments, or thoughts? If not, we can head towards a closure of this coffee and cases. Thank you guys for the interaction. I think it's been amazing. Word of the day is going to be ROSC. Amazing. Thank you, everyone. Have a fantastic rest of your week.